Okay. Hi, everyone. Welcome to the Epidemiology Seminar Series. I'm Angela Lee Wynn, an assistant professor in Department of Epidemiology at Colorado School of Public Health. Today we have Dr. Briana Mezuk as our speaker. And we're truly excited to have her give us her talk on stress, sugar, and status, psychosocial aspects of type 2 diabetes. Today's seminar is co-hosted with the Life Course Epidemiology of Adiposity and Diabetes Centers. Thank you, Lee Center, for co-hosting. Dr. Mezuk is an associate professor in epidemiology and the co-director of the Center for Social Epidemiology and Population Health at University of Michigan School of Public Health. She's trained as a psychiatric epidemiologist from Johns Hopkins Bloomberg School of Public Health. She focuses on understanding the intersections of mental and physical health over the lifespan, particularly on examining depression among older adults with diabetes and frailty. Today's seminar will be recorded and posted. Please put your questions in the chat box, and we'll monitor the chat box and read the questions we receive during the Q&A. So without further ado, please welcome Dr. Mezuk.
Thank you, Angela. It's a pleasure to be here with you all. I'm sorry I couldn't be there in person, but that's the life that we are in. So I believe this is the right screen. Angela, is that I'm good?
Yes, perfect. You got it.
Awesome. So I realized later that I had given a talk or topic for my talk, or title rather for my talk, way back in the fall when you invited me, and this title's a little bit different. So I think I was going to talk about the 3 Ds, depression, diabetes, and disparities. Now we're talking about the 3 S's, status, stress, and sugar, but the main gist to the talk will be the same. I also want to, again, this is a picture of my son from about a year ago when we first went remote with everything, with creating his awareness slide about coronavirus. And so the small joys we can take pleasure in these days. I need to, before I show you anything today, none of the work I'm going to talk about could have occurred without the insights and sweat and tears of my collaborators, including some people that are here on the call today. A lot of this work happened in conjunction with my collaboration with James Jackson, who many of you probably know of his work, and he passed away in September. It's been a huge loss for us here at Michigan and for the field more generally. Also want to call out my partners at the Richmond YMCA. I'll talk a little bit about the work that we've been doing towards the end of the talk, and then obviously the grant support makes this work possible. And I don't have it stated here, but I will state that I have no conflicts of interest to disclose. So I'm hoping to sort of hit 4 main ideas today. We'll talk about social disparities in type 2 diabetes and what that has to do with the translation gap between what we know about diabetes prevention and actually being able to prevent diabetes in the real world. Then I'm going to turn attention specifically to the role of stress and introduce you to a model that we've been working on for the last few years called the environmental affordances model, which focuses on the ways that stress and the ways we self-regulate our emotional state, how those relate to each other in context. I'll talk about 2 projects relate to the environmental affordances model, and then bring it back to the translation gap and talk about what we know about how stress relates to self-regulation, how that relates to addressing social disparities in diabetes. So just to make sure that we're all on the same page, I'm going to just do a little bit of definitions at the top. So there are 3 types of diabetes: type 1, type 2, and gestational. This talk is going to focus on type 2 diabetes. This is by far the most common form of diabetes, between 90 and 95% of all cases, depending on 90 and 95%. It is a state of hyperglycemia that's caused by insufficient insulin action or production. Every time I give a talk on diabetes, I have to update the prevalence estimates because every year it increases a little bit. And so the latest prevalence estimate are about 10.5% of the entire US population, which works out to about 34 million people. And fully a quarter of people age 65 and older have type 2 diabetes. Prediabetes is a state that we know increases the risk of developing type 2 diabetes. The prevalence is a little bit wider. This really depends on how you define it. If you define it just using hemoglobin A1C, you'll get 1/3 of the US adult population, or 88 million people, as having prediabetes. But the most important thing about prediabetes is that we know from large randomized controlled trials like the Diabetes Prevention Program and others that we can prevent, or at least delay, the development of type 2 diabetes through intensive lifestyle modification, even among people who are at this high risk state. Diabetes is extraordinarily costly, with estimates, close to $350 billion annually in direct and indirect cost. Now, like most health conditions, type 2 diabetes is not uniformly distributed in the population, but there are substantial social disparities in diabetes. This is what this looks like in the United States for education, beginning 1980 into 2014. And so what you can see is that while there were always some disparities in diabetes prevalence as a function of education, even in the 1980s, as the epidemic has unfolded over time, those disparities have widened. Another dimension by which we can look at disparities in diabetes is by race and ethnicity. And so what this is showing is the age-adjusted prevalence of diabetes for men and women as a function of race in the United States. This is just sort of prevalence. Have you ever had? What's not shown here, but which is also true, is that not only are racial ethnic minorities in the United States more likely to develop type 2 diabetes, but they develop it much sooner than non-Hispanic whites. Depending on the group, we're talking about anywhere between 5 to 10 years earlier median age of onset. And that matters because while diabetes is a condition that you can live with and can be managed, the longer you have this condition, the more difficult it can be to manage and the greater your risk of developing microvascular and macrovascular complications. Now, of course, these types of bar charts, which are showing you an individual characteristic, aren't, nobody exists in a vacuum, but instead people, whether we're talking about their educational attainment or race or ethnicity, exist in context. And here's an example of what that context looks like. You're going to see a map like this several times during this talk. So this is a map of Richmond, Virginia, where I used to live. Spent the first 8 years of my career at Virginia Commonwealth University at the medical school there. And what each one of these dots represents, an African American who was seen at a primary care clinic at VCU, that has prediabetes, so is an elevated risk of developing type 2 diabetes, overlaid with area poverty here. And what you can see is that there's a greater concentration of people in these higher poverty areas within Richmond. Now, the thing that sort of is interesting about diabetes, and you might sort of say, like, why would somebody like me, who's, as Angela said, my degree is in mental health, why am I studying diabetes as an outcome? Why is this talk not going to be about mental health? And it will be about mental health, but I'm going to get there through kind of a strange way, or maybe not strange way, different way, which is that unlike most mental disorders, where we don't necessarily have a good sense of how we could prevent, like how could we prevent depression? How could we prevent schizophrenia? How could we prevent anxiety? Those things are challenging to prevent. We have data from multiple large-scale randomized controlled trials that we can prevent type 2 diabetes, even among people at elevated risk. We can do it with metformin, which is a cheap, safe medication, and we can do it with intensive lifestyle change. And we've known this for almost 2 decades, how to do this. And yet the prevalence of diabetes continues to rise in our nation and elsewhere. And so this then is the translation gap. How do we effectively translate what we know from these prevention studies into the real world? And of course, this is not a new insight for many long time. This is a quote from Bill Cefalu. We've known that just because what works in a well-researched or well-resourced prevention trial, that doesn't mean that's going to be able to be as effective in a different infrastructure with different techniques, etc. But I'm going to say that I think this is actually even, it goes deeper than that. It goes deeper than what works at an academic medical setting may not work in your neighborhood, but rather that there was a disconnect between the people that the intervention that these trials were developed on and the people that we want to apply those trials to. And that disconnect has to do with status. So what I'm showing you here is a bar chart that, or two bar charts that the people in blue are the blue bars show the distribution of educational attainment of participants in the diabetes prevention program. And the green bar, and so these are people who've all got high risk of diabetes. They and they're randomized to either placebo, metformin arm, or the lifestyle modification arm. The green bar is showing you the distribution of people in NHANES that would have been eligible for the DPP. That is, these are people who have, if you were to apply the inclusion-exclusion criteria of the DPP into NHANES, what would the educational attainment look, or what would that distribution look like? And you can see that there's a complete disconnect. So the vast majority of people in the real world in the United States who would have qualified for the DPP have less than a high school education or less. You can compare that to the majority of people in the DPP had at least attended college, or if not, had an advanced degree. So now education is one indicator of status, and we'll talk about sort of what that means in terms of broader how it relates to diabetes disparities. But this is just one example of this disconnect between, or why we get the translation gap, I should say. Oops, sorry. So, going forward, people have sort of recognized that how do we try to close this gap? And so part of it is we need to think about the role of context. And I'm not going to debate this like 20%, like where, what proportion of the variation in health outcomes is medical care versus outside. We know that both are extremely relevant, but the question sort of becomes, what are those factors outside the system? When people talk about these social and environmental influences, what are those things? And then how does this then go back to addressing the disparities that we see in type 2 diabetes? So in 2016, the American Diabetes Association releases this position statement on psychosocial care for people with diabetes. And this statement, for the first time in sort of one place, codifies the importance of thinking about health literacy, food insecurity, diabetes-related distress, depression, and similar factors as influencing diabetes clinical outcomes. As somebody who's made my career studying how mental health, particularly depression, relates to type 2 diabetes in sort of a bidirectional fashion, I was really excited to read this statement. This is a little bit of a challenge to necessarily to sort of to what degree are psychosocial factors, sort of how should they be prioritized, or when should they be addressed in talking about diabetes care. And so to see this position statement out there was a really positive thing. And then I read the statement and was very disappointed. And so along with a colleague, Franz Power, we wrote a letter to the editor about this statement. And our main critique is that despite the fact that this statement talked about health literacy and talked about food insecurity and talked about diabetes-related distress and et cetera, it didn't include the terms disparity, inequality, or any of their synonyms even once in its text. That is, the conversation around psychosocial factors was completely divorced from the context, the kind of social context in which those factors vary. Food insecurity is not randomly distributed in the population. Like if no doctor should be screening me for food insecurity, for example. Like when I this isn't something like that they need to know my income, but then once they know that, that should sort of use that to triage where to whom are these factors most relevant, to where do we need to target. And so in order to actually have that position statement have any real meaning in terms of what it would look like in clinical care, there has to be an explicit connection between things like health literacy and food insecurity or diabetes related distress and status. So, but then the statement kind of gets me thinking, well, why is it that to somebody like myself, who's, sort of identifies primarily as more of a social scientist or a social epidemiologist, why is it such an apparent truth that psychosocial factors, particularly things like stress, are important to the emergence and persistence of health disparities, but it wasn't necessarily apparent to the clinical audience that the ADA statement was addressing? And this figure here is just an example of any, like, I'm sure you've all seen these kind of schematics, at least for those of you who are doing work on social disparities in health. You kind of see these, very simplistic schematics trying to explain how status gets to disparities. And almost all of the word stress is almost always showing up in these types of models. And so, well, why isn't this model compelling to clinical audiences? And I think there's actually two reasons why it's not, and that it helps me focus my own work on sort of what kind of research do I need to provide, what kind of work do I need to be doing in order to bridge this gap. So the two reasons why I think it's not self-evident is that the way that we measure stress, typically in epidemiologic research, is not tied to any particular biological system. That is, we don't actually specify the physiologic mechanism for how stress would impact disease, particularly a specific disease, something like type 2 diabetes. The second is that social scientists who study stress often discount or downplay the known causes of diabetes, which are health behaviors, smoking, physical activity, poor diet. These things we know cause type 2 diabetes. And yet they are not necessarily the focus of the work of many people who are studying stress. And so the work I'm going to talk about today is going to try to bridge that knowledge gap by focusing on the intersections of stress and self-regulation in context. And by context, I mean as it relates to status and disparities. So I now need to sort of introduce and make sure we're all on the same page with the idea around stress, coping, and health behaviors as they relate to diabetes risk. So if you remember back to sort of your Psych 101 sort of class, or just even your lived experience as, coping with stress, when we talk about coping, the main process the main model that we use to talk about is this kind of stress process model, which involves perception. So perception of something as a stressor. The second is appraisal. So appraising sort of what kind of, how threatening or challenging or, et cetera, is that stress that I've just perceived. And the third is the response or the coping response. And so coping refers to any cognitive and behavioral effort to kind of manage the internal and external demands encountered during a stressful situation. And generally, we refer to kind of 5 typologies of coping: problem, approach, support seeking, avoidance, distraction, and restructuring. But the ways that most of the field of psychology talks about health behaviors as they relate to stress is as health behaviors as ways that people avoid dealing with stress, or ways that people distract themselves from dealing with stress. That is, we don't talk about, psychology generally does not talk about smoking or alcohol use or drug use or exercise or prayer or meditation as those types of behaviors that people do to cope with stress as either things that are directly addressing the stressor, which are problem solving approaches, or seeking support, or cognitive restructuring. They instead are these negative coping things of avoidance or distraction. Now, and that's an old, I'm going to hopefully convince you that that's a, maybe not old model, but it's that model can be augmented by actually considering the physiologic and neurobiological correlates of these stress response, sort of stress coping behaviors, which I'm going to call self-regulatory behaviors, and I'll tell you why I'm going to call them that in a minute. So just to summarize on what these limitations of our current models of stress, coping, and health behaviors. So the first is that, and this is particularly, if those of us who are doing work in epidemiology know, that if we're trying to study the relationship between stress and some health outcome, you often need to, control for these health behaviors because they're confounders, right? They're going to be correlated with the stress exposure. They may be causally related to your health outcome, but we don't conceptualize them as being mediators of how stress leads to health outcomes. So instead, we sort of try to adjust for their role, but that's a very, as I'll try to convince you of today, that using that approach to address health behaviors when we think about the stress health relationship does not reflect some of what we know about the neurobiology of how those health behaviors relate to the stress response. The second major limitation is that the addiction perspective on health behaviors is not really well integrated into public health discussions of stress. And by addiction perspective, what I mean is the fact that health behaviors are reinforced. And if you know anybody who studies substance use for outcomes, there's two elements of that reinforced the behavior. There is the learned element of a reinforced behavior. So this is where sort of people will talk about if they walk by the outside of their building where they go out to have a cigarette every day, this can trigger a sensation of craving for nicotine because they've learned, kind of in a Pavlovian sort of conditioned response to whenever they're in that setting to do this behavior. But the second part of that learned behavior is the underlying physiologic drive that has to do with, sort of satiation and craving. And you can think about this whenever, obviously, you're hungry. You know what I mean? So we all know what it's like to have a physiologic drive, or thirsty or sleepy, these things. And so those two elements are not well integrated into this public health discussion of stress or how stress relates to health disparities. And the third piece is the piece I already mentioned, which is that most psychological approaches to coping frame health behaviors as either avoidance or distractions, versus that there might be some underlying neurobiological impact of these behaviors on the stress response. So more recently, and I think the NIH started this initiative, gosh, it's probably 5 or 6 years ago now. The NIH has this new initiative that they call the Science of Behavior Change. And what the Science of Behavior Change is a trans-institutional sort of initiative. And what they are trying to focus on is the idea that whenever we're making decisions, whether that's around what behavior to engage in or how to sort of, prioritize different things, that we have to that self-regulation is our ability to manage our emotional, motivational, social, and cognitive resources in order to pursue some goal, right? So if any of you try to lose weight, right, or try to exercise more frequently or whatever it is, that's your goal. But what are the things that you're doing to kind of self-regulate all the things that happen when you are, so there's to get in the way of you pursuing that goal? And so rather than sort of thinking about people lack willpower, or they, sort of just don't know what to do in order to lose weight, or they, whatever, it's instead saying, actually, we can think about self-regulation instead of from this very simplistic view of lacking willpower or lacking understanding, to instead say, actually, this is a really complex dance that people go through to try to manage these competing demands when they're trying to pursue a higher order goal. And they specifically say that those self-regulatory strategies may be more or less effective in different goal pursuits, and specifically in terms of goals that relate to mental and physical health. So we sort of already are beginning to get a alternative way to think about why people engage in the behavior they engage in, and what are the factors that make it difficult to engage in behaviors. So we propose this alternative model, which is pulling together stress and health behaviors, not just as health behaviors, but as reinforced behaviors that happen to impact health. And so this model depends on these three things being true. The first is that stress exposure impacts the likelihood of engaging in health harming self-regulatory behaviors, and that these self-regulatory behaviors in turn impact the neurophysiologic reactivity to subsequent stressors. The second is that these behaviors engage reinforcing circuits and pathways in the brain, which are themselves linked to the HPA axis and related stress response systems. And that third, that these behaviors can become conditioned responses, that is, learned responses over time, and therefore decoupled from the actual stress coping response that you see that is built up in number 2. Now, I'm not going to be able to unpack each of these claims sufficiently in the time I have today, but I will show you a couple of pieces of data from both animal and human studies that just give you a taste of sort of the type of research that makes us believe these three things are true. So this is a study of rats who were genetically identical, and they are randomized to get one of 4 chows, right? Options they get to eat. There's control chow, there's chow with sugar, there's chow with fat, and then there's the equivalent of a rat Twinkie, that is the rat with sugar and fat in it. And these rats are stressed out, and they're stressed out they put them in a little paper towel hole, like the middle of a paper towel hole, roller, sorry, the thing that's inside your paper towel. They put a rat in there, and the rats don't like it because they can't move around. And then they let them see how much they want to eat. And what you can see here is that rats who are randomized to get a high sugar or a high sugar and high fat diet, they eat more after being stressed than rats who are randomized to get the regular chow diet. Now, that in and of itself is interesting, but what's really interesting is if you sacrifice those rats and you look in their brains, the rats that were randomized to get the sugar, fat, or high sugar and fat chow are literally making less corticotropin releasing factor, which is a precursor to the corticotropin releasing hormone, which gets into your HPA axis. That is eventually going to result in your adrenal glands releasing cortisol. Their brains are making less corticotropin releasing factor, suggesting that physiologically, the rats that ate fat or sugar after being stressed are making less stress hormone than the rats that were randomized to eat the regular chow. This is a different study showing rats that are randomized to either get sucrose, so fat is not part of this study now, sucrose or water, like water vehicle, right, as an injection. And so the rats, and what I'm showing you here highlighted in pink, are the behaviors that those rats are engaging in after they get the infusion either of water or of sucrose. And the rats who get sucrose, they are engaging in more social interaction with other rats. They're also engaging in more sniffing behaviors and kind of stretch, attend postures. In the final panel down below, they spend more time in like the open arms of the rat maze, enjoying themselves. What's interesting in panel B is that this study compared the effect of sugar to the effect of D, and D in this chart is diazepam, which is Valium. So now rats don't like being, these are rats that look less stressed. That is, they are behaving in a manner that they are feeling more calm after having sugar as compared to water. This is suggesting that the sugar is actually shaping their behavior, right, going forward. That is in a manner that is more approach oriented. But of course, humans are not rats. So this is a study in humans. So these are people who are randomized to either drink for 2 weeks a sweet tea. Half of the group is randomized to drink glucose sweetened sweet tea, and half are randomized to drink aspartame sweetened sweet tea, which has no calories, but of course has the same sort of sweet sensation. So pre-intervention, what you can see is that both groups have very similar, the y-axis here is cortisol, very similar responses to a stressor, which is the MIST. I can't remember what the MIST stands for, but it's a sort of laboratory intervention to evoke a HPA response. So pre-intervention, it's similar, that is pre-randomization to, are you going to get aspartame, are you going to get sucrose? And then if you could look post-intervention, you see the reactions are completely different. That is, the group that 2 weeks later, after drinking sucrose sweetened sweet tea for 2 weeks, that they don't react to the MIST when they get in there, even though they had reacted before they'd been randomized. So here is an example of an increase in the consumption of sugar resulting in a more blunted response to a stressor longitudinally. Now, that experimental evidence is completely consistent with qualitative work that has been done for many years on this sort of tension between effective management of diabetes and dealing with the diabetes distress or just emotional distress more generally that comes along with this condition. This is a quote from a work by Jennifer Brayland, which says, "The day I stopped worrying and said, I'm going to eat everything. I don't care about diet or sugar or anything. I checked the sugar and it was good." So stop worrying, because if you have in your mind diabetes, 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 you are traumatizing yourself with this illness. And in this work, as you can see the bottom part of this table here, when she's talking about the different themes that these focus groups in this case came up with, one of the things was the trade-off between eating familiar, comforting, potentially unhealthy foods that were associated with feeling less stress and potentially even lower glucose versus eating the healthy foods that would cause stress. And so, that people with diabetes, especially in the context here, this was a sample of lower income African Americans from New Jersey, was showing this tension that actually trying to engage in these behaviors was having completely opposite sort of effects of what people, what the doctors would recommend that you do. And this quote, which is, also just really summarizes to me the real sort of connection that people is very consistent with the experimental data that I just showed you. This person, again, this is an African American woman who has diabetes, and she says, your mental health helps you be able to say, I'm going to be normal on Friday. On Friday, I'm going to go out with my friends, eat what I want to eat, drink what I want to drink. On Saturday, I'll be a diabetic again, but on Friday, that's a diabetic holiday. So she's specifically tying her mental state to the behaviors that she's engaging in to feel less stressed, in the context of this disease. Now, of course, her hemoglobin A1C may be 14, right? But the point is that she's able to specifically tie the challenges of trying to adhere to this regimen that her physician wants her to adhere to, and her mental health. Okay. So what do we know so far? So we know that there's a complex, nuanced relationship between stress and health behaviors. And Mark Twain, of course, summarized this for us beautifully when he said, the only way to keep your health is to eat what you don't want, drink what you don't like, and do what you'd rather not. So then what we hypothesize, based on what we know, is that social structures and context shape exposure to stress and the opportunities to self-regulate, and we're going to specifically say in terms of health behaviors, which then contribute to social disparities in health. And this hypothesis is sort of formalized within this framework that James Jackson developed called the environmental affordances model of health disparities. And the first three pieces of this model are not, I would say, innovative in and of themselves. The first is that stress is associated with risk of both mental and physical health problems. That when faced with stress, individuals engage in coping behaviors to self-regulate those feelings of distress. The third is that the specific set of things you do to cope with stress is shaped by context. And by that, I mean place, gender, race, ethnicity, and socioeconomic status. And that these self-regulatory behaviors may have differential effects on mental and physical health. And that last point is the key innovation of this model. And you might even say, why is that necessary? Why would we say there might be differential effects on mental health versus physical health? But of course, as you just saw from the quotes I just gave you for people living with diabetes, they specifically talked about things that were good for their mental health versus things that were good for their physical health. But there's also these sort of pieces, this other additional element or layer that we have to engage with. So how do you know if somebody has diabetes? You, you gotta get a blood test, right? So in fact, there's a lot of people who have diabetes, and particularly people who have prediabetes, have no idea about it because it's asymptomatic, particularly at the beginning. But how do you know if somebody has depression or is anxious? There is no blood test for depression or anxiety or schizophrenia or any psychiatric disorder, but rather you need to ask somebody, you need to talk to them, or you need to observe them. And so the piece of it is, because the only person who knows if you've had depression is you, that there's this element of conscious awareness that you know about. That's different than diabetes. You can have diabetes and not be consciously aware of it because you don't know what your blood sugar is, you don't know what your blood pressure is, or you don't know what your cholesterol is. Like, this is not something that's part of our conscious awareness of our bodies. But every one of you could tell me how you slept last night. You could tell me if you feel distracted. You could tell me if you are feeling guilty, if you're feeling irritable. And those things all together are depression. And that also means, because you know about these symptoms of depression, because you're consciously aware of them, it means that you can do things to moderate your emotional response to stress in a way before it becomes clinical depression than you could when it comes to diabetes. And so the way that James developed this model, which is articulated here in the schematic, is we see that chronic stress increases risk of depression. Chronic stress increases risk of diabetes. This is very consistent with things like allostatic load and other models like weathering. That chronic stress causes people to engage in self-regulatory coping behaviors. I just showed you some data on that a minute ago. And the only bar that or arrow that everybody agrees on is that if you drink too much, smoke too much, eat the wrong foods, and don't exercise, that those things cause type 2 diabetes, which is the red arrow. And then the thing that the innovation of this model is the blue arrow, which argues that if those self-regulatory coping behaviors, if the things that you're engaging in are actually reducing, they may potentially reduce your risk of clinical psychiatric syndromes like depression and anxiety, because they may be effectively ways to cope with stress. If stress causes depression, coping with stress should prevent against depression. But what if with the ways that people are coping with stress are things like eating high fat and high sugar foods, or smoking cigarettes, or drinking, right? And you might say, like, why do I even need this arrow? This doesn't make any sense. Well, the reason we need that blue arrow is because when we actually look at the distribution of mental disorders and medical conditions in the population, the sort of story around social status and health does not align. So what I'm showing you here is the lifetime prevalence of major depressive episode, generalized anxiety disorder, diabetes, asthma, and hypertension, and data from the National Comorbidity Study replication. And what you can see is that African Americans are more likely to have diabetes, asthma, and hypertension, but less likely to have major depression and generalized anxiety disorder relative to non-Hispanic whites. And this is true. I could have shown you, lots of other data that is consistent with this. And so, why is this the case? Why would we not see status being related to both poor mental and poor physical health in the same way that sort of our general health disparities models argue? And the reason for that, we think, has to do with these self-regulatory health behaviors. And we've actually tested this specifically this is in the Baltimore ECA study, where the x-axis here is stress, self-report stressors. The y-axis is the probability of depression 13 years later as a function of stress and the number of poor health behaviors. And so this is smoking, drinking, and poor diet is this index that we created. And what you see for non-Hispanic whites is what you would expect to see, that as stress increases and the more poor health behaviors you engage in, the more likely you are to be a case of depression in the future. But for Blacks in the sample, we see the exact opposite. And in fact, the group that, what we see is that as stress increases, the group that's most likely to engage or to be a case of depression 13 years later is the group that's doing all the things I'm sure their doctors are happy to have them doing. They're not drinking, they're not smoking, and they're not engaging in poor diet. And that disconnect, I guess, is, or this sort of issue is, again, brings us back to how we think, why we think this is happening is because that these are not just health behaviors, but rather these are self-regulatory coping strategies. Now, you are probably thinking to yourself, like, why would this be differential based on race? Doesn't everyone prefer Twinkies to Brussels sprouts? Sorry, my dog needs to come in. And we argue that this has to do with the differential experience of disadvantage and advantage over the life course as a function of social group. And as James would say, race matters, even though we don't know what it is. And what we think it's serving as is as a proxy indicator of that is the residual that is capturing the physical and social environmental factors that are not completely indexed by socioeconomic status. So I was very ambitious and thought I was going to talk to you about two different projects, but I'm not going to be able to do that. I'm just going to talk about one, which is going to focus on the question of how stress exposure and stress reactivity relate to diabetes risk. We want to do this project, the reason the sort of theoretical framework for why we want to do this project is the idea that any project that's going to try to understand social disparities in diabetes has to have indicators of the physical environment, the biological environment, and physical environment, biology, and psychology, or that these ideas around stress and coping. But unfortunately, it's especially for doing work on minority health and health disparities, there aren't a lot of data sets that actually have this type of data that would help us interrogate the intersection of all three of those variables. But despite the fact that we didn't have this data in sort of large, kind of diverse samples, there is good data, and this is data from Andrew Steptoe that was published in PNAS a few years ago, suggesting that stress reactivity is disturbed or dysregulated, if you will, among people who have established type 2 diabetes. And so here, what I'm showing you here is the figure from his chart. And so what we sought to do was to sort of bring together these big ideas of where do disparities in diabetes come from? How does this relate to stress reactivity? And then how is this going to relate to self-regulation in one study? And that study is a project called the Richmond Stress and Sugar Study. This is a cohort study of African Americans and non-Hispanic whites who are at high risk of developing diabetes. The sample I'm going to show you today is 125 people, aged 40 to 70 years old at baseline. Something that was innovative about this project is that we had a 2x2 sampling frame. That is, we recruited African Americans and non-Hispanic whites, each from neighborhoods of high SES and low SES. We could do that in Richmond because the South kind of area of our nation is much more racially integrated than other parts of the nation. There's lots of historical reasons as to why that's true. The thing that we did that made us sort of innovative is that we collected HPA axis stress reactivity using the Trier social stress test. And so this is just kind of this figure on the bottom. I'm happy to answer questions about this later. So it gives you a schematic as to how we actually did our data collection. So here's a map of Richmond again. And now the dots here are, again, looking at median household income, although darker colors in this map indicate greater income. And I'm showing you our distribution of high SES and low SES, both African Americans and non-Hispanic whites. This is the distribution of our stress reactivity as a function of race and neighborhood socioeconomic status. And what this graph shows is that you can see, first of all, everybody sort of gets stressed out as we hope they will, and there's about a 15-minute delay from there. The Trier social stress test, just in case for those of you who don't know, is a laboratory paradigm where you bring people in and they have to give a 5-minute speech in front of a panel that is unfriendly, or I shouldn't say unfriendly, they're non-responsive. And then after you give this 5-minute speech, you have to do some mental arithmetic, which is quite challenging. And if you, so it's a 7-minute long sort of stressor. And then we are measuring salivary cortisol using a salivette, chewing on a salivette tube over this hour and a half period of time. So what we are able to see, and you can see through this graph, which I'll just summarize here, is that race and neighborhood socioeconomic status were associated with differential aspects of HbA axis reactivity. That living in a lower SES neighborhood was associated with higher so higher baseline cortisol before we stressed you out, a shallower increase in response to the TRIR, and a steeper decline than people who are living in a higher neighborhood socioeconomic status. We also saw only one, but one sort of main difference by race, which was that the cortisol decline was greater among African Americans relative to non-Hispanic whites. But we also saw no sort of evidence of differential vulnerability to poverty as a function of race. That is, that we tested race by neighborhood socioeconomic status interaction terms, and these were small and not significant. The other thing I want to sort of bring up is that we have this additional challenge, which we have this measure of biological stress reactivity, but most of our measures in epidemiologic search are simply relying on self-report. And what's difficult, or so the sort of the dirty secret, I guess, about this is that a lot of these self-report measures of stress, they aren't necessarily correlated with cortisol. And in fact, the data on cortisol and stress and health is kind of a hot mess. And so what do we, here we had a situation where we had good measures of stress reactivity through the TRIR. And then we also happen to have good measures of self-report measures of stress exposure. So how did these relate to one another? And what we saw here, again, which is consistent with the graph I just showed you about neighborhood socioeconomic status, except now what I'm showing you is on the left tertiles of the perceived stress scale, and on the right median split of the perceived stress scale, is that people who reported more stress on the perceived stress scale, and we also have another measure where the findings are consistent, have a less robust response to the TRIR than people who report less stress, which is consistent with kind of theoretical arguments around allostatic load, weathering, and kind of similar ideas as to how we get cumulative wear and tear on the body, which which would be a mechanism by which how stress would relate to poor health over time. So I'm going to stop. I'm going to show you 2 more slides, and then I'm going to stop. And I'm so sorry, I was way too ambitious because I want to make sure we have time for questions. The 2 things that I hope you take away from today are that disparities in diabetes are not inevitable. These are graphs from Tom Levise's work in his in his studies looking at non-Hispanic whites and African Americans who are living in the same lower income urban neighborhoods in Baltimore. And what you can see is in these EDIC neighborhoods, as compared to the National Health and Nutrition, National Health Interview Survey, is that you see that the disparities, the white-black disparities in these EDIC neighborhoods are much, much smaller as compared to the national differences. And the reason they are smaller is because non-Hispanic whites in these low-income urban areas are much more likely to have diabetes than non-Hispanic whites in the general US population. Again, pointing to the importance of context as a factor that's driving disparities. So then I told you at the very beginning about the psychosocial statement that the ADA comes out with, well, what a difference 4 years make. So just last, I guess, December now of 2020, the American Diabetes Association releases a new, this is not a statement now, but this is a scientific review on social determinants of health. And this is led by Felicia Hill Briggs. And she writes, as a clinical context alone is too narrow to accommodate these influences, that we need to have structural and legal interventions to address root causes driving social disparities of health, that we need to, in the next generation of research that prioritizes interventions impacting the root causes of diabetes inequities rather than on compensatory interventions for assisting individuals to adapt to inequities. So just, I mean, night and day from the 2016 statement, which talked about health, helping people learn how to read nutrition labels better and helping people, get access to food banks. Here, just a completely 180 view and say, no, no, now this is not about teaching people to adapt to inequities. This is about addressing the inequities. And I am going to, I met Angela through MeWe, which hopefully some of you have heard about. If not, we have our application cycle is open for one more week. This is a training program where we are focused on training interdisciplinary scientists interested in the intersection of mental and physical health. So please look us up and apply if you are interested. And the last, honestly, last slide, and again, I'm sorry for going so long, is just to emphasize that any effort to understand disparities in physical health has to be cognizant of the multiple complex ways that physical health is shaped by and shapes mental health, and that these interactions are at the center of the work that I'm doing. So with that, oh my gosh, I'm so sorry about that long thing, but there you go.
Thank you so much, Bree. I think we have 2 questions so far.
Sure.
Michael, do you want to unmute yourself and ask your question if you're still here?
Yeah, definitely. Hi, Dr. Bree. Thank you so much for being here. The talk was absolutely fantastic and super illuminating. So yeah, thank you so much. But my question was kind of relating to that talk, I think it was in Baltimore, relating to the patients that were detailing their emotional trauma associated with their care for diabetes. So I read a paper last semester in a different course that was kind of touching on the paradigm in which diabetes is treated as kind of one of the roots issues for this emotional trauma or disconnect between disconnect, I guess, between the treatment, because, I think one of the quotes was on Saturday, I'll be diabetic. And that was kind of the same vibes that were in the previous paper I read. So I wanted to just ask about that connection that you see between, individualistic versus this kind of other paradigm that you are presenting. And
that's a great question. That's a great question. I understand what you're saying. The idea that, people who have diabetes, every time they have a meal or before they have a meal, you check their numbers, and there's kind of constant reminders of, not with type 2 diabetes, that's not as natural. Although if you're taking insulin, you do. And sort of you live and die, or you rise and fall with those numbers. And good physicians will, of course, tell people, don't pay attention to the numbers, don't get down just because your number's high and things like that. But of course, why am I measuring this? Why? It must matter because I'm checking it all the time. I didn't get a chance to talk about it today, but I'm happy to send some papers and some work that we've done with our community partners at the YMCA that have a community-based diabetes self-management program, where it's a group-based program, and people, it's not only are they supporting each other, but they're supporting, they're sort of helping each other to feel confident asking their doctors different questions and engaging, sort of in their care in that way. Because I think that it's interesting that when you talk, we have a community advisory board, there's a lot of physicians on it, and the physicians will sort of be talking about values like confidentiality and privacy. And so this is why they don't want to necessarily do group visits, even though they see the benefit for the patients. But that's sort of on the list of 15 things you got to worry about. That sort of thing is not actually high on the list, but rather feeling not alone, wanting encouragement, being able to share the struggle and be with people who actually know what it's like to not be able to go out to eat with your family, or go out to eat with your family, but know that, your sugar is gonna, people talk about I'll just say a prayer and hope that, I can get through it, and that sort of piece of it, I think, is this individualistic, I think, is sort of that's the contrast to what you're kind of talking about. So I think there's a good understanding, or I think there's growing appreciation for it from physicians, but there may be other structural factors, whether that's around payment models or sort of different ways that we think about care, that are still slow to disseminate into a more team-based approach that might be more consistent with that. So I see Anna's question here about social support. So this is in John Henry's, and it's your question, your timely, this question could not be more timely. So I have a master's student who's working on John Henryism right now. And this is a concept that I'm learning more about through her project. And, certainly what John Henryism gives us is the idea that there's a cost to adaptation. And that is an idea that is not well sort of appreciated, I think, in terms of when we think about coping and sort of what is the time scale at the cost and where does that cost happen. So John Henryism, of course, begins with the idea looking at coping and hypertension and cardiovascular disease, but, and which again is focusing on this trade-off between, kind of mental health or psychological coping and then cardiac outcome, sometimes decades later. But the idea that we would, sorry, let me back up. And your question specifically as to race factors, racial differences. I think John Henryism likely plays a role in the way that any so I think it plays a role. I think we don't have as many good studies that have sort of comprehensive measures of this construct to unpack it as much as we do some of the other metrics that we have. But I absolutely think it plays a role. In the same way, I should also say things like religiosity and other factors that I didn't have a chance to talk about today certainly are part of the story. The question is sort of where in the life course are they most salient? When, even in time, are they most salient in terms of chronological time? But it's a great question, Anna, and it's a good point.
What outcomes is your student looking at in relation to John Henryism?
She's looking at depression and suicidality in the National Survey
of American Life.
Yeah, in the adolescent sample.
Okay.
So teens in the adolescent sample.
Yeah, I had the good fortune of meeting and actually publishing with James Jackson once, and those measures are prominent in NSAL, which I'm sure obviously you know. So I just thought that was interesting. But one other thing that you said in responding to the prior question made me think about, and I just want to get your opinion on it. So I'm a project manager with LEAD for the Search for Diabetes in Youth study here. And so my work, I interact with a lot of people who have diabetes, both type 1 and type 2. And anecdotally, one of the things that a lot of the participants have said is that sometimes it's hard to out yourself as a diabetic. So your question when you ask, like, how do you tell if someone's diabetic? It's the regulation, not just of yourself, but also other people saying, should you be eating that? Or can you have that? But then also the other people trying to say, well, it's a special occasion, so this can be your holiday, that kind of stuff. Where it's hard, you can't have it both ways kind of thing. And when you think about how many of our social interactions as Americans are centered around food, and then if you break that down even more culturally in Hispanic communities, in African American communities, in any like ethnic community, food and rejection of food is a major faux pas. Like, so if you're thinking about norms and mores and things like that, to not take grandma's macaroni and cheese, or to not take the tamales or whatever, and that kind of how that affects you, both in terms of, is it worth the aggravation and the rejection of that person to take the hit, as you say, to get like I'm going to have a reading of 250 on my glucometer, but I'll know where it came from, so it's okay, and how do you do that if that's every day?
Right. And I mean, I'm Italian, so like I can tell you, like you gotta, as soon as I walk into my grandfather's house, it was, you haven't eaten. When have you eaten? Time to eat. So, but I would also say, I think that level, so yes to all of that. And then I would say, and the fact that we see this neurobiological response, that it's not just that the tamale makes you feel good emotionally, like physiologically, it actually has an impact on and especially if we're talking about chronic stressors that come with minority status, whether this is financial stressors, whether this is occupational, stressors, whether this is discrimination, other sorts of things that are just sort of in the air. What are you able to do to self-regulate in response to that? And then it isn't just this one time, right? And it's every moment of every day, right? The same sort of pieces. And so I think but it also then gets us to change the conversation around, this isn't about willpower. This isn't about, you don't know how to read a nutrition label. This is about, there is a physiologic response here. And so, for example, like some of the work we're doing now in the stress and sugar study is looking at these different coping behaviors as they relate to stress reactivity. And we find very similar relationships between eating behaviors, so eating fried foods, for example, and stress reactivity, as we do meditation. Now, meditation does not drive your sugar up, right? So if we can demonstrate that, then this can be potentially like actually integrated into a self-management program, which would say, okay, so you are thinking, you know, this is how you're feeling. What are some things I can, rather than just say, don't do that, I can say, do this. And this is, I can point physiologically to how this is actually going to address something you care about, which is your emotional state. You care about your numbers too, but you eat that tamale today, you're not dying tomorrow, period. Like that's just not how that's going to work. That's going to the time to pay that piper's coming 5-10 years down the road. But the time to pay your sanity piper is this moment. That is the time to, the release you will feel is immediate. And it's not just in your head, it is in your body that the release comes from. So I thank you for bringing that additional level of kind of cultural layer onto it. And I feel like this is a both and situation where we see that. And I think this is also going to help us convince the clinical folks why this matters, because they're looking at the numbers, right? And they're looking, they're the sort of set of things that when I read that psychosocial statement, I was just like, why was this so disconnected from the social scientist perspective on, I couldn't believe that they wrote something about food insecurity that didn't mention the word inequities. I'm like, who is food insecure? Like, where's this? Like, this isn't just dropping out of the sky. Like, this is a part of a system.
Well, I'm a sociologist by training. And I think a big part of it is going back to, and my sociology is showing, to think about, is this a personal problem or is it a structural problem?
Right. Yeah.
And so like when you're looking at stuff like that, there are things that you have control over and things you don't have control over, but trying to figure out the ways in which you can maneuver within that. And I've heard it referred to somewhat as a vice tax of like, okay, I'm willing to take the hit and I'm going to eat this thing that I know is bad for me, but I'm going to go, get on the stationary bike for an hour later, or, something like that. And then maybe something happens that you don't actually do it. There's stuff that happens that prevent you from doing things, time, family commitments, whatever.
Yeah. And I think what the way to kind of build that into the structure with your sociology is what shapes the options people have to choose from.
Right.
And that if we can, and the things that shape the option set are things like racism, things like class, that's up here. And so if we can then reframe this as what shapes the options you have to choose from.
And then understanding that and then meeting that with the clinical piece, because I think that especially if you're seeing a clinician that comes from a different background, they may be less receptive to like what I was talking about, if I go to this Christmas party or whatever, and I don't eat anything, everyone and their mother is going to be on me about this. And it's just not worth the aggravation, those kinds of things that, or you go to the church social or, these kinds of things. And religion can be very important in a lot of different cultures that, just understanding and then giving people the tools for how to meet them where they are and understand those perspectives that maybe the clinicians don't have.
Right. Yeah, I agree.
I thought your talk was great, by the way.
Thank you. I'm sorry. I don't know what I was thinking with how much I had to show you. I was like watching the timer. I was like, man, that's, I got to figure out a way to start somewhere on slide 15 and then get to you. But again, if you're interested in this, I have lots of papers I can share with you, and please, I'll throw my email in the chat real quick. And Wei, thanks for having you here for our CSEF alum, which is always exciting to see. Sorry. So this is me.